Most older adults get their care daily, not in the hospital or the acute care setting. They actually get it in the care at home space. And interestingly enough, here in the United States, by the time we all hit 2030, the last baby boomer will have turned 65. And around that time, older adults will outnumber children less than 18 for the first time in our country. And I think that demographic shift, that demographic milestone is something that we are starting to feel today. Your care doesn't just start and stop in the hospital. And I think I oftentimes share with patients what happens to you in the hospital, like the tip of the iceberg. And 80% of your care is what's after the hospitalization.
There's a quote that I grew up with in hospice, but I've just recently revisited. Sometimes when phrases become cliche, we lose the richness and the wisdom, but it's when basically hospice is about adding life to days when days can't be added to life. But now we know people getting care from a good hospice, we also can add days to life.
And now our host, Chris Comeaux.
Hello and welcome to TCNtalks. I'm so excited today. We have a guest. Our guest today is Dr. Khai Nguyen. He's a geriatrician and age-friendly care champion for care at home with CHAP, Medical Affairs and Innovation at the Community Health Accreditation Partners. Welcome, Dr. Nguyen. It's so good to have you.
Well, it is wonderful to be here, Chris. Thank you very much. Thanks for inviting me.
I want to read from your bio. So Dr. Nguyen holds a profound interest and a passion for the convergence of health policy and medicine, which is pretty cool. Dr. Nguyen is a board-certified physician in internal medicine and geriatrics, and he is a former hospice medical director. He provides comprehensive care to senior patients, prioritizing disease prevention, managing chronic illnesses, and geriatric syndromes, and preserving their functional abilities. Dr. Nguyen completed a fellowship in geriatric medicine at the University of California, San Diego School of Medicine, and a residency in internal medicine at Scripps General Hospital in La Jolla, California. He earned his medical degree from the University of Vermont College of Medicine in Burlington, Vermont, and he holds a master's degree in health policy and certification and health finance and management from the Johns Hopkins Bloomberg School of Public Health. His health and policy experience includes previous work at the Centers for Medicare and Medicaid Services, CMS, Division of Health Promotion and Disease Prevention, where he contributed to the Healthy Aging Project. So, Dr. Nguyen, I am so excited. What maybe I left out, or what would you want our audience to know about you?
Well, first of all, Chris, thank you very much. And I appreciate the audience joining us today. I always don't imagine how long that is when someone else is reading it, but I think that the roles that I took on was really a journey towards, geriatrics and age-friendly care. And for me, Chris, it started when I was 12 years old, believe it or not. And at 12, my dad, who was significantly older than my mom, he had suffered a stroke. And at that time, that really changed a lot of things for me, not only as a 12-year-old, but ended up changing the trajectory of which I wanted to go down. And over time, I just realized that, seeing the doctors, the nurses, all the healthcare professionals, mainly a physical therapist comes to mind for me helping my dad after his stroke. These were the individuals that I wanted to emulate. I wanted to hopefully be one day to kind of help people like my dad. So that was what shaped me to be a future healthcare professional and eventually go down the path of public health medicine, and led me to take care of older adults like him. And seeing him and his healthcare journey and his set of illnesses, where he became more frail and more frail as time went on, then developing dementia, was something that touched my heart as a son, and eventually as a student, and then into a professional and a physician and a public health practitioner.
I love that. And first time you and I, it's Court Kastner who connected you and I. He goes, "You've got to meet Dr. Nguyen." And when we did connect, and you shared that story, and I could tell it just comes from a deep place of passion and authenticity. You are, and you want to make a difference in healthcare, and you're doing it with a really unique skill set. If you don't mind, I'll give you a compliment. You're a unicorn when you put all of those things together. And I mean that in every sense of a positive way as it possibly could be. Well, I've really been looking forward to this show. I have fallen in love with the concept of the 4 M's. And so Marcus Escobedo from the John A. Hartford Foundation, he was on the podcast earlier this year. And there's something in the way, like I had heard of it before, but there's something in the way that Marcus, and I'm kind of a history buff, the way like how it came to be, it's almost like I saw the light. Like, this is amazing. And so, and we'll put maybe the show notes for folks to go back and check that one out too. And so how we got to the 4 M's is just, again, it's amazing to me. And thinking about your background. So we're going to go there next about the 4 M's.
Sure.
But first, maybe you want to talk a little bit, because maybe it could further from your personal story. But the fact that you bring your unique unicorn skill set, but having such a strong background in geriatrics, how has that perspective maybe shaped the way you think about quality, safety, person-centered care and healthcare, and how you're bringing that to CHAP is just so cool. Which, by the way, we're huge CHAP fans. We
Yay.
looked at we vetted all the other accrediting bodies, and we said, you know what, we need an accrediting body we could recommend to our members. And CHAP is who we actually partner with as TCN members. And
That's
now
wonderful.
we do have a couple of members who are age-friendly certified. So the
Yay.
4 M's is bubbling up kind of from the ground up within TCN, which is super cool.
That's wonderful, and really appreciate the work that you do. But I before I answer that question, is I just wanted to really share my gratitude for not everyone joining here, but also for Court Kastner, who made this connection. Court has been just a really influential figure and a thinker and an innovator, on our board and leading our board. So that's always been appreciated. Additionally, you mentioned Marcus, Marcus and the John A. Hartford Foundation. What this work could not have been done, and the very foundation of the work could not have been done without the John A. Hartford Foundation, Terry Fulmer, and the team there. So a big shout out to John A. Hartford. Thank you very much. And in the work that they're doing with the Institute for Healthcare Improvement as well. But also, the work being done, CHAP does center and root from the work that you're talking about with geriatrics and that geriatrics perspective. And when I was asked to join CHAP several years ago and think about medical affairs and innovation, is what can we bring to the care at home space? And at that time, I had just completed bringing age-friendly care to the health system where I'm at, which is University of California, San Diego, and I'm a professor of medicine there and help to teach geriatric medicine. The key thing there is that, bringing age-friendly care to a large health system and hospital back in 2015, 2016, that was something that was what was being kind of touted at that time. And that's where all the funding streams were. But what really affected me in thinking about, most older adults get their care daily, not in the hospital or the acute care setting. They actually get it in the care at home space. This is where most older adults get their care. And, when I had an opportunity to work with CHAP and really the wonderful team there, not just the leadership, but all the way up to the site visitors and our teams and specialists, I realized this is the team to help bring age-friendly care to the home space. So we worked very hard to work with the Institute for Healthcare Improvement, and we were awarded not one but 2 grants to help bring age-friendly care at home. And CHAP is the first accrediting organization to help bring age-friendly care standards to the home space. And by virtue of that, we were the first to help bring age-friendly care certification into the home space for home health and hospices at first, and then a subsequent grant that brought it to private duty caregiving, and we continue to the goal to expand, because if we can bring age friendly care to the care at home in the community setting, then I think we can influence more people. But I think I didn't answer your question on the geriatrics there, because it was so there were so many pieces there, and I think we can't move on from the beginning part of the answer from gratitude, and I think a lot of age friendly care is gratitude of older adults who are oftentimes not only our grandparents but our parents, like me, and who contributed so much to not only our lives but our society.
That's so good. And you're reminding me so much, and maybe I'll just give a couple of talking points of what I feel like I learned from John A. Hartford, and you clean it up if you need to, Dr. Wynn. But thinking about, like, we have a generation shift occurring. I've got 30 years now in hospice, so we cared for the greatest generation. So the baby boomers are now coming into healthcare throughout the whole country, different aspects of all of our different verticals that we have throughout healthcare: hospitals, skilled nursing facilities, ALFs, home health agencies, hospices, etc. And so the baby boomers have not gone quiet in any part of our economy ever. And so this is a major shift. And the 4Ms is a framework that deeply, I think, would absolutely have resonated with the greatest generation, but very much resonates. And so the 4Ms is a great framework to be a age-friendly organization. Would you say that differently, or would you clean that up?
I wouldn't clean it up. I would add to it if I can. I mean, I think the very structure of what you're saying is an appreciation and respect of a generation that has really helped to build this country to where it is. And I think that, even though we have challenges, but every generation has challenges, I think we just have to meet it. And I think as part of meeting this challenge for the baby boom generation, it really affects us down the line, because it is one of the largest aging populations. And the thing that still is most interesting to me is that most, I would say, even doctors and nurses I work with may not know that we are currently in the decade of healthy aging, and that's according to the World Health Organization from 2021 to 2030. And the purpose of that is to really celebrate this global aging phenomenon that we see. And interestingly enough, here in the United States, by the time we all hit 2030, the last baby boomer will have turned 65. And around that time, older adults will outnumber children less than 18 for the first time in our country. And I think that demographic shift, that demographic milestone, is something that we are starting to feel today. We are starting to feel it in our daily lives when we're taking care of our moms and dads and our grandmothers and our aunts and uncles. But also for those watching, is you're feeling it in your daily work, and that frustration of how are we going to meet that challenge. And so when the rough get going, the tough get going as well. I think I misstated that Billy Ocean song, but I think he'll forgive me.
Well, I think we've got our listeners like hanging on the edge of their seat. What is the 4Ms?
Aha.
Oh, yep. So can you briefly explain it?
Sure. I think that is key to really understand what the age-friendly care and the 4Ms are. But as I describe the 4Ms of care, I'll describe how they came about in a few moments. But let's not have people hang at the edge of their seats. The age-friendly care is essentially described by a 4Ms framework that was developed based on evidence. And so number one, the first M is actually what matters. It's the matters part. And what matters is about knowing, aligning the care of each individual older adult and how their specific health outcomes connect with that. And what are their goals and preferences? We're not just talking about limiting it to end-of-life care, but we're talking about current goals of care and across all care settings. So that's what matters. Then we now move into mentation. And mentation is really the brain health and mind, and thinking about how in the work that we all do is preventing, identifying, treating, and managing dementia or major neurocognitive deficits, but also coexisting depression. And in cases where we're talking about acute care, post acute care, is how delirium can oftentimes affect that care and be prevented. The next M is medications. And the idea here is that, there are medications that affect older adults more significantly. I know we oftentimes hear the beers list, but, medications generally that do not interfere with the other M's. And we think about it in all care settings. And it doesn't mean that older adults shouldn't be on some of these medications, but that if they are on it, that we do have a way of considering deprescribing the lowest effective dose and really limiting those to the best possible way. And the last M, but not least, is mobility. And, oftentimes, we think about mobility is about allowing older adults to move safely around their home and their environment, maintaining and preserving their function. And the key thing here that I just want to share with the audience is that when we think about these four M's, I've been told before, it's something that we already do, Dr. Wynn. It is something that you already do, but you may be doing in separate pieces and portions. But the key thing here is to really work with it as a set. That's the innovation in age-friendly care. Is that when you think about medications, you think about it how it may affect an older adult's mobility and how their mobility affects what matters to them if they want to be taking their dog out for a walk or gardening or being with their family, and also how mentation is affected by medications. And then, so it's really something that all connects with one another.
That's so incredibly well said. And I think probably the first time I heard it, we have an incredible team member, Raquel Braithwaite, who actually grew up in hospice but spent time in senior living, and she was the first person to share it with me. And I think I kind of had that, and it's that horrible human condition that AI is making worse. Been there, got the T-shirt. Oh yeah, the 4 M's. But there's something about the way Terry first with Jenny Hartford and then Marcus communicated it that is like, oh, wait a minute. This is profound, and this could actually be, I think, very powerful for our future. So I'm going to repeat them for our listeners because I have them now memorized. And so what matters, medication, mentation, and mobility. And so how do you see that, Dr. Wynn, translating specifically into the hospice and palliative care environments, since that's where most of our listeners are?
Yeah. So, I think it fits perfectly in that because, with home health and hospice, and in the care at home, your care doesn't just start and stop in the hospital. And I think, I oftentimes share with patients what happens to you in the hospital is like the tip of the iceberg. And 80% of your care is what's after the hospitalization. And really, when we think about the 80%, we are thinking about oftentimes home health, hospice. Sure, there's outpatient care where I do clinic as well. But when we think about that, is that if someone's on home health, they are getting skilled care to get back to where they were. There is a what matters to why you want to get back and to regain your skills and preserve your skills for your mobility, but also that's affected by what medications you're on, perhaps new medications that you're on. And not all those new medications are going to be medications a person's going to be continuing throughout. So, and then, of course, we can't forget the mentation aspect as well. That's still very important. But for a home health organization and home health team to come in and understand how to use the 4 M's effectively will lead to better outcomes. This is an evidence-based care and practice, is that, when they thought about bringing the 4Ms to light, meaning the Institute for Healthcare Improvement, was they brought in all experts nationally, and they said, hey, let's look at all these models of care for older adults and geriatrics and what works. And they brought in an interdisciplinary team, and they distilled it down to the 4Ms. And they said, if you practice the 4Ms, each older adult patient, each time, every interaction, then you will have achieved evidence-based care in medicine. And the same, very similarly, goes for hospice. And I certainly respect that home health and hospice are not the same thing. Mm-hmm. But the similarity in the care and the dignity of care, I think, is even ever more so when it comes to home health and specifically for hospice. We are thinking about end-of-life care. And oftentimes, and I think I'm really speaking to the crowd here when you may hear, well, hospice is about giving up, and I always share with families, it's not about giving up. It's certainly a different philosophy of care, but there's still so much medicine, nursing, and care to be practiced and to be provided to you as a patient, and that care oftentimes can be age-friendly care. And I think that, again, this is a rather simplified framework, but oftentimes, we're going really back to the basics and the foundational pieces when I say basic.
Thank you to our TCNtalks sponsor, Dragonfly Health. Dragonfly Health is also the title sponsor for Leadership Immersion courses. Dragonfly Health is a leading care-at-home data, technology, and service platform. With a 20-year history, Dragonfly Health uses advanced technology and robust analytics to manage durable medical equipment and pharmaceutical services as part of a single efficient solution for caregivers, patients, and their families. The company serves millions of patients annually across all 50 states. Thank you, Dragonfly Health, for all the great work that you do.
Yeah, there's a quote that I grew up with in hospice, but I've just recently revisited. Sometimes when phrases become cliche, we lose the richness and the wisdom, but it's when basically hospice is about adding life to days when days can't be added to life. But now we know people getting care from a good hospice, we also can add days to life. And so it's life to the full. And in many cases, sometimes people do live more deeply in their time in hospice because they're faced with their own mortality. And there's beautiful things that could occur. And what I've recently, the light bulb is going off is, in using that framework, like, do we know what matters most? One of the stories, Dr. Wynn, I fell in love with hospice at 25. That's how young I was when I came in. And our hospice would ask that question, what matters most? And it was a dad and son that had been estranged for 35 years, had not seen each other in 35 years. The long story short, our volunteers arranged a fishing trip because that's what mattered to them. They were both under hospice care at the same time, had no clue.
Oh, wow.
And obviously a heartbreaking story. Obviously the son was much younger. And then the dad died like 2 weeks later after that reunion, but just beautiful, just like, oh my gosh, what is this thing? But because they asked what mattered most, this amazing reconciliation occurred before the dad passed away. And then actually the son was on our care for quite a while, actually. And so when I think about like bringing that in on a day-to-day basis, and of course, the medication, there's a lot of good deprescribing. There's so many contraindications and things because the left hand and the right hand don't communicate in the rest of healthcare. I'm seeing new frontiers. Now there's some pharmacogenomics, I think that's the right word, that are coming in, even like how they metabolize different medications. It goes down to the gene level. Mobility. We don't do therapy as often as we probably should in hospice, but you have to be thoughtful about that, a CHF patient versus other patients. And then the mentation side is so funny. I came in, taped this podcast. We have these future councils that we've actually conducted this year, that there are 8 challenges facing all hospice and palliative care programs. Well, one of those future councils is mental health, because we're seeing the lack of a true mental health care system in our country washing up on the shores of our hospices. And now we're seeing more challenges, like we literally in this meeting, just a really horrible situation that's now in the hands of this hospice, that there's so many other points of failure in the rest of the healthcare system. And now you got hospice people that really don't exactly have the right tools, that are caring for someone that is terminally ill, but it's really a mental illness that's actually leading that situation. So I can see where these 4 M's are almost like, be careful. People are like, oh yeah, been there, got the t-shirt. No. I think there's a whole new frontier here where we could go deeper and become even better experts of doing that well. Would you say that differently, or?
Yeah, I would say that while I do recognize for our colleagues that the hard work and the just, really the hard work and the effort that we all put in every day to care for our patients, it's not that that's not the right work, but it's really thinking about how we can do it better, more efficiently, and then we think about quality and what makes sense, right? So all those things that you said earlier are really moving us from good to great. And I think that yes, it does take effort. It does take effort, but I think it's well worth effort, especially when getting from good to great and being more efficient is actually easier. Oftentimes when I do talk about, and what I want to add on to what you were saying is that, not another program, Dr. Wynn. We don't want to do one more thing on top of what we're already doing. Please don't add something else. But age-friendly care in the 4Ms framework is not about adding a new program. It is about a paradigm shift in care on things that honestly most of our audience is already doing. But doing it now with intention and keeping in mind that connection between what matters, mentation, mobility, and medications, is very key in how they interact with one another. And I'll just share with you a quick story here. I was with a medical student, and I really enjoy working with medical students because they all come from various backgrounds, just like you and I, right? And this particular medical student, it was right before lunch, and I was sharing my 4Ms like I just did to you all. And my medical student says, I don't want to be mean to you, Dr. Wynn, but we already do all those things. We get a POLST, a physician order for life-sustaining treatment, or in some states, it's a MOLST, right, for medical order. We already reconcile their meds. We ask them about their medications. We have them, they're getting up out of bed in physical therapy, and we also making sure that their mentation is well as well, and we check up on them and ask them the PHQ-9 and so forth. And I said, well, okay, that's good, but they still don't understand that sort of the interaction. So I said, well, let's identify here. It's about lunchtime, and we're all both getting hungry. I go, what do you enjoy doing? And the medical student says, I enjoy baking. So I go, okay, let's choose baking as an analogy here. And I said, well, if I gave you flour, eggs, sugar, and chocolate, if you ate that alone and each of the ingredients alone, would it taste good? Would it be chocolate cake if I asked you? And they go, oh no, that would be gross. That would make not sense. It no sense at all. You're just eating the ingredients alone. And I go, aha. So in order to really bake something in and make a good chocolate cake, you have to put a lot of, TLC in there and mix things up. And that is truly baking a cake. And then you have your chocolate cake, right? So they said, yes, that makes sense. And I said, that's the thing with age-friendly care, is that you really have to, it has to be baked into care. And when you think about the cake, once it's fully done, you can't be like my 9-year-old son who just eats the icing only, And I said, if you want to enjoy a cake, you got to enjoy all layers of the cake. And this cake is 4 layers. It's what matters: medications, mentation, and mobility. And so, and you got to eat all 4 layers to really get the sweetness of the cake. And, we just have to let them eat cake.
That's really good. I love that analogy. I'm going to definitely quote that one several times. And would you also agree, Dr. Wynn, that and I love your graciousness, because yes, most really great hospice and palliative care teams, they are attending to the 4 M's. But I also wonder, just like great medicine, right? There are always new frontiers being discovered. There are probably frontiers of our thinking about these 4 M's and then how they also synchronize together that are probably yet to be discovered. Like, how can we re-look at it fresh eyes? Like the one I poked on, I don't know if you would agree, but I do think that there's probably some level of therapy that could become part of standard of care in hospice that is very rare currently. And I think as we go into the baby boomers, and I hope our listeners don't miss this, the customer is changing. If we were running a typical business, we would not lose the fact that, well, wait a minute, what does the customer want? The customer wants the 4 M's, and the customer wants it incredible. They have wanted the best of the best in every other part. Why is Starbucks a thing? All these interesting, great experiences now, vacation homes and experience vacations.
Sure.
I mean, baby boomers were the leading edge of all that. And we would be incorrect to just go, been there, got the t-shirt, and we're going to do the hospice thing into the future with the baby boomers like we've done for the past 30 years.
Yeah, I do agree with you. I think that, this is care is, it's not just a target, right? A target assumes that we are going to hit it at some point.
Mhm.
Certainly we do target good care. I think that's wonderful. I think we should be precise and as accurate as possible. But I think it's a moving trajectory because there are expectations to what is quality, right? What is value in care? And I think with the baby boomer generation, I don't pretend to know everything about this amazing cohort, but it is something that we do have to meet, and that challenge of that. You also mentioned that, hey, physical, therapy, right? Physical therapy, mobility. I think that there are certainly aspects of maintaining, preserving function that we ought to really consider. Is that as people are, especially in home health, we know that, but even with hospice, I think yes, we do see that as end of life care, but we still have to really focus on all these aspects that really help to help people have that quality of life. And a part of it is mobility. It's not just being bedbound but again, I think we're preaching to the choir here, but I do think at some point that has to move and change. Absolutely.
You've also alluded, I love that you've used good to great several times. And so this is beyond the scope of today's show, but I have this theory that revisiting good to great, like there's something about this season where we are, and I've noticed you've used it several times.
Yeah. I mean, it's a very good book. And the piece here is I hear it oftentimes an awful lot that, it is hard in the mix of daily care, to be, we're doing good already. This is good work, and it is good. But I think it's one of those things that if we aim for the stars, and we hit the skies, that's great. I mean,
Right.
And perhaps that's not the best analogy. I'm sorry if I'm
No,
not
actually,
the best at analogies.
I think it's actually really good.
Yeah, but I do feel that the work that we all do, sometimes we do feel it's just good, but it's actually great to most of the world. I think that, whenever I get a chance to, I'm not out in the field as much anymore. I'm mostly relegated to the clinic, as you can see with these scrubs. But whenever I do get out to do a home visit, I do get out to observe care at home. I got to say, I get tingles talking about it because I think that's where great work actually happens. When you're in the hospital, and I'm not picking on any nurses or doctors working in the hospital here, but the hospital is this very specialized space that is, state of the art, and it has all these tools and everything. And you can get a lot done in there. And sure, great things happen in there, but nobody wants to be in a hospital, right? And when people are home, and they're getting care, even the simplest, basic but foundational pieces of care can be great. And I think that the work that really, I'm just speaking to the audience here, that you all do every single day, home to home, door knock to door knock, is that it is great work. And I think that great work deserves to have a foundation with great evidence-based care, because a majority of people you take care of are going to be older adults, and older adults of this generation that I agree with you, Chris. I think people do expect great care.
Another question I'd like to run by you. I have a theory since I've again fallen in love with the 4Ms. We've struggled most of our, at least I know, well, beyond my 30 years, even before, about how to talk about hospice. And so Dr. Bayak recently, I'm a great admirer of Dr. Bayak. We've had him on the podcast, and he wrote a strategic framework about the path forward for hospice. And he had 4 components of it. One of them was, he called it the authentic brand of hospice. And I believe what he's saying there is, how do you talk about what we do in such a way that the patient and family will receive it? Because today, when you use the word hospice, oh no, we're not ready for you yet because we're not dying tomorrow. Hospice has become synonymous with death, and it creates this great wall of communication that we can't get beyond. And so here's my theory. I think the 4Ms gives us a framework to talk about what we do in such a way that the patient and family will hear it and go, I need that. And we don't have to use the word hospice. And it's not like we're trying to fool anybody. I mean, there will be paperwork that says hospice, but we could talk about what we do in a way that actually they understand, as opposed to, oh, no, I'm dying tomorrow. And then they can't receive it. And one last thing, and I'd love to hear you respond. And this will be for those that are watching. We have this amazing team member, Tina Gentry. She used to do this great presentation in the community. And she'd point to her head and say, you understand hospice. In other words, you understand in your brain. But once you experience it, she would then put her arms around her heart and she would say, and now you really understand what hospice is. And it's like, you've almost got to do those motions to connotate to people that after you experience this, you have a much deeper understanding. Unfortunately, because the words that we use, people then don't choose it. 50% of people in America still have 14 days or less of care, which is horrible. It's a 6-month benefit. It's a beautiful benefit. It's as much for the caregiver as the patient. So all that to say, my theory is the 4Ms is a way to talk about what we do without having to use that word. What do you think?
No, I honestly have not thought about that until you during this interview, as you were just sharing that. I think the 4Ms can be used for that. I mean, I think that's the wonderful innovation in that. And, as strange as it may sound to you in the audience, but, for some of my patients and their families who really do need hospice, I mean, it's something that I feel at the core, it's not just the philosophy, but really the benefit, the number of benefits people have, and the ease of care made easier and more efficient. I do say, look, at the end of the day, the key components of why the doctors feel that you would benefit from hospice and your care would benefit from hospice are there. And you're paid into the Medicare system. It's something that, should not cost extra to you at all. But you can call it whatever you want. You don't have to say, the hospice program. There's no requirement that I'm aware of, Chris, that says you have to call it hospice. And I'm not suggesting anyone here to lie to family members, but really, for instance, I think about hospice as a journey as well, right? Speaking of my journey into age-friendly care and geriatrics, is hospice is like a journey. I remember, so we're huge Disney fans in our family, so we love going to Disneyland, Disney World, and Disney cruises. But oftentimes when we refer, as something as wonderful as Disneyland and enjoying it, we don't always say it's our Disney vacation. We just say it's our family vacation. And it's not that we're lying to one another, but it is. It is our family vacation. And in a way, when people are getting care in hospice, you're getting care. You're getting the best care. You're getting age-friendly care. You are getting care towards the end of life, yes. But I really appreciate what your colleague said, you understand it in your head, but you feel it in your heart. And we all do know that. A majority of people, you're right, do get care just in the last 2 weeks. It is something that I think we're going to hopefully help people shift away from that. But I think what's also affecting that too is that there's this, not only is it in the mind and the heart, but it's also in wallet and regulations that, there's a lot of regulations on hospice, and there's also a lot of press on hospice, with perhaps some negative press on it, which is not helping it as well.
Yeah, what we said in a prior podcast, so Cord Kastner actually and I, that, hospices that we take what we're talking about in the 4Ms and go, this is a framework. You know what? We're going to make sure our team is highly skilled in these areas. Yes, we're good today, but we're going to become great in those areas. We're going to go all in on that. We're even going to think about our language and how we talk about, we're going to think about our marketing around this. I think that's a road less traveled, and what's getting the negative press, they're not even in the same game as that. They're playing a different game that's fraud and very icky at a very vulnerable time of people's lives. And if you're the trendsetter in some business, you're not talking about some podunk, crappy business that supposedly is in the same industry as you. You're setting the standard. And that's where I'd like to put our energy going forward, which again is why to me these 4Ms is just brilliant, which maybe leads a good segue. So how is CHAP then helping organizations move forward towards becoming more age-friendly? And do you see the 4Ms influencing how those accreditation standards and quality metrics then evolve? Because then it could be assisting kind of this vision that we're painting with each other.
So that's a two-part question. And so the first part is yes, CHAP, Community Health Accreditation Partners, having received two amazing grants from the John A. Harper Foundation. So we are the ones that are working with the standard bearers of this movement. And I think there's something to be said about that, because, the Institute of Healthcare Improvement, we still work with them very closely to make sure that all the work that we're doing continues to align and grow with the movement. With that said, though, developing the first certification, that certification is the first set of standards. And the way I certainly look at it, and the way we look at it at CHAP, is that your certification is the foundation of quality for which you can launch off from. And I think having that badge that says age-friendly care certified at home is important. It is good to celebrate it. It is good to share it with your community, that we are an organization that really thinks about the care that we provide for our older adults, but beyond thinking about it, we actually accomplish it. So that's something that is available to any organization that is newly interested in their accreditation, and also organizations that are recertifying. And the interesting thing is that there is no additional cost if you are initially certifying for getting and essentially applying for the age-friendly care at home certification, and also for recertifying. There is no additional cost in addition to obviously your site visit fees. So that's something that I think is just another bonus.
It's a total bonus.
It's not a new program, and it's not a new fee either. And it's because we do believe that this is something good and great for our organizations to be able to consider, and not at the end, but the final result is it's good patient care. There's a second part to that, though, Chris.
The second part was, do you see maybe the 4Ms influencing the standards and quality metrics and how we evolve into the future?
Yes. It's not only if I see it, it's already happening.
Sweet.
Now, some of you may have already heard in 2024, I think towards the latter half of 2024, the Centers for Medicaid and Medicare Services that administers Medicare now has approved, and it is running, a CMS age-friendly measure on the inpatient service. So for hospitals, they required now in 2025 to report out if they are doing the 4Ms of care. So, I think that is a huge step, because any hospital that participates in the Medicare, I think it's the IQR reporting program and essentially receives Medicare is at risk of, losing money and dollars and funds down the line if they don't address the 4Ms of care. And I think the 2025 is going to be a report out structural measure. And then I think as the years go on, as we can imagine, it's going to be then attached with a certain level and percentage of accomplishment. And so, and we do know sometimes that what happens in the inpatient and hospital acute care setting oftentimes finds their way washing up on our shores in home health and hospice. And so even if it isn't happening now, I think it's going to happen in the near future.
Okay.
But even for organizations that are hoping and wanting to work with a certain hospital that is needing to fulfill their structural measure, but you also say, oh, we are also age-friendly care certified. We also practice age-friendly care. It's the same language to be able to market and directly have conversations with and really distinguish your organization and your practice from the myriad of others in your community.
I totally agree with that. I think that's brilliant. So as we start to land the plane here, if you could share one or two calls to action for hospice leaders in particular listening today about embracing age-friendly 4M-based care, what would it be?
I think the one or two calls to action is, firstly, you're already doing it. Joining this podcast, learning about it, and if you said, "Oh, I already know about it," great. This is a good other impetus to say, you know what, maybe we should take a step towards age-friendly care and have our organization move into that space. There are resources on CHAP at chapinc.org or the Institute for Healthcare Improvement as well. And I think that these are the first steps, and there's usually no cost for the first steps. I mean, time is always a cost, right? But I think time well spent is an investment that has dividends of return on that one. So the first step you've already taken, and the second step is to move forward into that space. Contact us and start your journey. Start your journey from good to great. And if you're already great, you could even be greater. Right?
Absolutely. So there's no there.
Yeah, exactly. So I think that with this moving trajectory of care, it's just staying on top of it and having the 4Ms at your side is just, it makes it run so much more efficiently.
That's so good. Yeah, no, thank you, Dr. Wynn. Thank you for the work that you're doing, because I really do believe that the 4Ms and the age-friendly initiative is, I think the time is now. And again, kudos to John A. Hartford, because they deserve a lot of credit. We actually are connecting with IHI. We're going to probably have them on a podcast as well. So we're going to keep singing this from the mountaintops, because as I said, we believe that number one, it's the right thing to do. It's where the customer is wanting us to go. Interestingly, I have a family member who is diagnosed with Parkinson's, and it was back in the fall. And then in the spring is more when I first really connected deeply with what the 4Ms was really saying. And then going back to that whole care experience and thinking, oh my gosh, this is what was missing. And, thank God I'm in healthcare, helping a family member traverse this kind of just labyrinth that we've created in healthcare. But it's really what I was grasping for, because I knew what was most important for that family member, but didn't have a framework to even have the communication with them. I was trying to be that Rosetta Stone between them. So there's just so many applications, I believe, to what you're working on here. So again, major kudos to you and your team. I'm obviously pretty passionate about it. We're going to have links to the 4Ms within the CHAP website, and anything else you want to share with us, we're going to include those.
And so I do have the quote here. So the quote is, and I actually had this in my college essay, but I think it has really followed me through and throughout as I went on through my journey to become a geriatrician and in this space. And it's a quote from pilgrims that were requesting permission to sail to the New World. And it reads, "It is not with us as with other men or people whom small things can discourage, or small discontentments shall cause to wish themselves home again." And, that holds true to me because, it is that perseverance it is that desire to not settle with what is good or what is great and even go for something that is greater. And I think that we are all going through a time in our new world in healthcare, in this new healthcare that is coming up. And to me, 2030 is a number in a year, but in order for us to get there, we do have to have these building blocks to continue to build upon a foundation. And I think that the 4M's, age-friendly care and age-friendly care certification, can be that foundation for you as a health professional, but also for your organization, and to continue to build on top of that. And don't let these discouragements and discontentments wish for you to go back or home again, that we can go forward. So I thank everyone very much. And again, gratitude for Chris for inviting me here and for everyone's time. Really appreciate it. Thank you.
Thank you, Dr. Wynn, and thank you for the work that you and CHAP and just all the wonderful people that you're influencing. And to our listeners, we thank you. Be sure to hit that subscribe button. Pay this one forward, especially to your friends, your coworkers, your colleagues, not only within your own hospice, but other hospices you know as well. We want the 4Ms just to catch on like wildfire so we can make a great difference as we go forward into this future. So, Dr. Wynn, thank you, and thank you to our listeners. Appreciate you listening to TCN Talks.